Hi Dylan, I'm Molly Johnson. I'm a nurse practitioner. I'm going to do your cardiovascular exam today. One of the first things you want to do as you examine your patient is just make a general observation of them. Dylan is resting comfortably. He's in no respiratory distress. His color is good. His cheeks are pink. He doesn't appear to be anxious. Can I see your hands? He's got good color, warmth of his hands and his legs, and go ahead and put your arms out like that. And does not appear to have any excessively long fingers or arms that would be indicative of Marfan's, no kyphosis or curvature of the back. Check the conjunctiva. Just going to pull down gently below the eyes and look at the color inside the conjunctival sac. It's nice and pink.
General observation, pulse and respiration can be done with the patient up on the exam table or sitting in a chair, but blood pressure is more accurate sitting in a chair, so I will transition the patient now.
I'm going to feel your pulse. So at this point, we want to compare the radial pulses and feel that they're symmetric. And then once I've done that, then I can time the pulse in one wrist for 15 seconds. And as I'm timing that, I can also mention that if the pulse was irregular or if the patient was a baby, that we would time for a full minute. While I'm doing the pulse, I will also start paying attention to the respirations, but not mention it to the patient because they might change the way they're breathing if they know that I'm watching. You can just hold the pulse for like 30 seconds. The first 15, you're counting the pulse, but you're kind of watching the respirations, and then when you switch over to respirations, then do that for 15 seconds. Okay? And then for blood pressure. What you want to do is make sure that your patient is relaxed, that their feet are flat on the ground, that their back is supported, and that their arm and the location where you're going to be listening is about at the level of the apex of the heart. And so this would be about right. If it's up too high like this or just hanging too low, then you're going to get inaccurate results. So this is a good position for him. For the sake of the test, you do not need to wait 5 minutes. You can just verbalize that you would do so. There's a line that indicates where the artery is. In this case, it's in Spanish. I'm not quite sure why. And then this gives you an idea. This line on this part of the cuff, once it's wrapped around the patient, should fall in that range if this is a good size cuff. The other measurement that you need to check is to see that it's about
40% of the circumference of the arm.
I like to kind of push the gown up and roll it up out of the way so it doesn't get in the way. All right. So then for placement of the cuff, you want to make sure you get the artery line about over the brachial artery. You don't want it right down into the antecubital space, but about an inch above. Get this part firmly against the skin and then engage the Velcro. Okay? So this is a two-step technique that we're going to teach you. The first step is that you pump up the cuff until you no longer feel the radial pulse. And then let it down. And whatever level that was, then you go 30 millimeters of mercury above that when you go to listen. Okay? So that level was about 120. So I'm going to go up to about 150. It's okay to go a little bit higher. And then I want to drop it down once I release it about 2 to 3 millimeters of mercury per second. And his blood pressure, the systolic is when I hear the first sound, which was at 116, and the diastolic is when the sounds disappear, which was at 64, which is a great blood pressure. Okay. And then we would do that in this arm and then repeat it in the other arm. You would always want to do that whenever you have a new patient, or if you have a patient that is having blood pressure problems, cardiovascular complaints, you want to check on both arms. Okay? And basically the technique is the same. You can either position him so he's got his arm up here, or in this case you can hold the arm as you use the cuff and listen. It's a lot easier if you can rest their arm on the leg rest. Dylan, we're going to check your orthostatic blood pressure now. Could you come sit up here? And I'm going to have you lie back. Accurate orthostatic blood pressure, you would want your patient to lie down for at least 5 minutes. Some sources say 10, but at least 5. And then you would go ahead and you can be getting ready to take his blood pressure while you're timing it. For the sake of the test, you do not need to wait 5 minutes. You can just verbalize that you would do so. And so in a lying position, I would take his blood pressure. I actually know approximately what it is based upon the previous reading. So that was 120 over 54. And then I would want to check his pulse. And I would do this for 15 seconds. Then what I want to have him do is stand up. So I'm going to have you stand up all the way. And are you feeling dizzy or lightheaded? Are you okay? If he was dizzy or lightheaded, then I would immediately lie him back down. But since he is not, then I would go ahead and check his blood pressure. Again, though, being careful to hold his arm so that where I'm listening is about at the apex of the heart. I would check his blood pressure again, and then immediately afterward, then I would check his pulse. And then lastly, you can just verbalize that you would repeat those 3 minutes later. Okay, so you can sit back there. That's what I'm doing. Back. Now, I'm going to go ahead and drape you. Do you feel more comfortable with the gown on, or do you feel comfortable taking your shirt off, or what would your preference be? I'm going to demonstrate the exam with the gown down, but also show how to do it if you had a female patient. But let's have you. Are you tied up in that? So let's first just show the anatomy, and then I'll do the exam as if you were female. So go ahead and lay back. So it's important to identify landmarks when you're doing the exam. Right here is the sternal notch, and then the sternal angle is just, you can just feel like a little ridge down a little bit farther. Directly to the side of that is the second rib on either side, and the intercostal space, the second intercostal space, is directly below the second rib. Those are your landmarks for listening. You want to listen at the aortic, pulmonic, and these are right adjacent to the sternum, not far out, but just next to it, at the second intercostal space, over here on the left side. The third intercostal space, you can kind of palpate the ribs and then move down one more, would be Erb's point. And then the fourth intercostal space is tricuspid. And then you go to the fifth and you move over to the midclavicular line, and that's your mitral area. So that's where you're going to listen, and that's also areas that you will need to palpate. So first, I'm just looking and noticing if I see any pulsations. I can see the PMI pulsation right there, but no other ones on the chest. Okay, and then we're gonna put your gown back on, and then do the rest of the exam as you would for a female patient. So for female patients, of course, you're not going to expose the whole chest. So what you can do is just lift this up and make sure you have it untied, and you can pull this down. So then the breasts are covered, but you can get to both the aortic, pulmonic. Tricuspid, usually you have to lift up a little bit to get to that location, and then mitral, I usually go from below. Okay. All right. So if I was observing, I would just look, and then look down here and see if I could see the PMI. Okay. Then for palpation, you want to use the palm of your hand just right at the fifth intercostal space and see if you can feel the PMI, which I feel is beautifully right there, right where it's supposed to be. And then you want to put your hand right along the left sternal border and see if you feel any vibrations, which we call thrills, but I don't want you to call them thrills. I don't want you to tell your patient you're feeling for thrills. Just say you're feeling for any vibrations or any heaves, which is like pulsations, a lot of pressure up against your hand. And I don't feel any of those things. Then with my fingertips, I want to feel right here at the, just above the sternal notch. And then just put my fingers tips right next to the trachea and see if I feel any like a pulsation or a pulling or a tugging. And if I did, I would then want to check to see if it corresponded to his heart rate. Okay, but I don't feel any of those. All right. Then for auscultation, you're going to listen in those 5 areas, and you're going to use both the bell and the diaphragm. My stethoscope, I have a pediatric and an adult, and my bell is when I just press it very lightly. You can think of pressing so lightly that you wouldn't leave any indentation on the skin, and the diaphragm is when I press it down more firmly. So that will give me different sounds. I'll hear a higher pitch sound when I'm doing the diaphragm, and I'll hear the lower pitch sounds when I'm doing the bell. You can do it one of 2 ways. You can go through all 5 areas doing the diaphragm, listening for the high pitch sounds, and then you can do it again with the bell, listening for low pitch sounds, or you can press lightly, then press more firmly at each area. If you do that, you need to verbalize that you're changing the pressure by which you're applying the stethoscope, so that we know as examiners that you're listening with both the bell and the diaphragm. So light pressure, more firmer. I'm listening, I don't know, 3 to 5 seconds. Longer, of course, if I heard anything, if I thought I heard a murmur. Then I'm going to go to the 3rd intercostal space on the left side, pressing a little firmer. Tricuspid, which is the 4th intercostal space, pressing a little firmer. And then lastly is mitral. Now if I heard a murmur, let's say I heard one here, I would want to move my stethoscope slightly around the area, inching it, to find out where I heard it the loudest. Okay. I will just demonstrate the exam again with the gown down so you can see the landmarks a little bit better. And that down, we'll just leave that there. You doing okay? Mm-hmm. All right. So I'm going to do the technique where I just press the stethoscope lightly and then more firmly. I feel the sternal notch, sternal angle, and the second rib, and then the second intercostal space. So this is aortic, pressing lightly, pressing more firmly. Pulmonic, lightly, more firmly. Moving down, just one inner space, lightly, more firmly. Around the 4th to 5th intercostal space is tricuspid, lightly, more firmly. And then mid-clavicular line is mitral, more firmly. So if I heard a murmur in this area and I wanted to make it louder so I could hear it more clearly, I would ask the patient to lean over onto their left side. And that would bring the heart a little bit closer to the chest wall, and I could hear it better. And then you can go ahead and lay back. Also, if I did hear a murmur in the mitral area, then I would want to listen in the axilla for radiation. And specifically, you'd be thinking about mitral stenosis or mitral regurgitation in that area. For the aortic stenosis or hypertrophic cardiomyopathy, you can listen along the left sternal border. Probably Erb's Point is a good location, and then ask the patient to bear down, close their mouth, or tighten their abdominal muscles, and hold their breath for a second. Okay, that's good. I would be listening, if I heard a murmur, to hear when he did that, if it got louder, it got softer. If I was doing a sports physical, I was just checking to see if I heard a murmur at all when I did that maneuver. Okay.
Additional cardiac maneuvers, sitting and standing, could be done at this time, or the JVD could be checked while the patient is already lying down.
Go ahead and check the carotid and the temporal arteries. So we can listen first, and you want to definitely make sure that the patient holds their breath. Otherwise, you're just going to hear breath sounds. So you're just off to the side of the trachea. Ask the patient to take a deep breath in. Okay, go ahead and breathe. And then you want to make sure you definitely do both sides, and then take another deep breath in. Good, great. I want to go ahead and auscultate the temporal arteries here. Normally, you don't hear anything if there's not any stenosis. We palpate the arteries later down in the checklist, but while you're here, if you wanted to go ahead and feel the carotid, you definitely don't want to do both sides at the same time, just one at a time, and then you can feel the temporal arteries. I often don't feel anything there, but there we go. There, I'm feeling it. Okay. All right, now we're going to do jugular venous pressure. For the JVP, you want the table to be at about 30 to 45 degrees, and then you need to have the patient turn their head over to the left, and you're going to be on the right-hand side looking. And you're going to look for an undulating pulse of the jugular vein. And it takes a little while for you to watch, but eventually you'll see it. If you're not 100% sure, one technique you can try is just kind of trying to occlude it at the base and then releasing it, and then sometimes you can see the pulsation better.
You look for the jugular pulsation, ideally under the sternocleidomastoid, but the external vein can be seen lateral to that. And then you identify the area where you no longer see pulsation, and that is the point where you measure the pressure.
One way to enhance the visualization of the jugular is to do lighting from the side, and sometimes you can see the pulsation better that way. You can also look for the pulsation of the carotid, which is going to be bounding and regular. You can actually see it on him right there, and compare that to the more undulating jugular. Once you identify the jugular pulsation, then you're going to need to measure it. So you want to go to the sternal angle, and you're going to use your ruler. There's one in the drawer, or you can use one that you might have. You put that directly on the sternal angle. You determine the height, the highest place that you see the pulsation, and then you use in this case, a popsicle stick to try and determine how many centimeters that would be, and making the tongue depressor about parallel with the floor. So anything below 3 would be normal. If you didn't see any jugular pulsation, possibility the patient might be dehydrated, you want to lower the table and then look for it again at that level. The last thing you want to do for the jugular is to check the hepatojugular reflex. So you're going to apply pressure in the right upper quadrant, and you're going to watch the jugular distension. A normal, healthy person, when you do that, you might see the pressure go up for a few seconds, but then it equalizes quickly and goes back down to its baseline level. You would press here for about 10 seconds and then watch for the response. Again, going up is okay, but then equalizing quickly is a normal response. So now I'm going to have you sit up.
When you sit the patient up, you can listen for an S2 split by just having the patient breathe normally. Listen along the left sternal border and note if the split is fixed or whether it comes and goes with inspiration.
And then I'll go ahead and lean forward. And that again brings the heart a little bit closer to the chest wall, so it accentuates any murmurs that I might be hearing in this area.
To augment the sound of a pericardial friction rub and the murmur associated with aortic regurgitation, you can have the patient exhale and hold their breath.
If I did hear a murmur along the left sternal border and I thought about aortic stenosis, then I would want to listen up in the neck to see if there was any radiation of the murmur up there. Okay. Lastly, we're going to do the squat and stand maneuver, which is very similar to what goes on when you do the Valsalva. This is another technique, so if you don't mind standing up, I'm going to listen here. We're going to squat down together.
Okay.
I'm going to listen long enough so I can hear if there's a murmur, then I'm going to come back up again, and then I'm going to listen again. So first, we'll just loosen this up a little bit so I can get here. All right. Listening for a murmur. And then we're going to squat down. and then we're going to come back up again. Okay, and that's fine. You can sit down a bit. Now we're going to take a look at the skin on his extremities, noticing that he's got cat scratches, but good color. We also want to check for turgor, and in adults you can check that by just pulling up the skin and seeing how quickly it goes back. In children you might want to check that on the abdomen. Looking at the nails for cleanliness and any signs of paronychia, any kind of redness along the nails, which I don't see. There's no spooning. Could you do that with your thumbs? No clubbing. Normal color. We've got very brisk capillary refill. On the legs, he's got normal hair growth down onto his legs. He's got good capillary refill here as well. And just taking a look for any warts on his, he does actually have a wart on his foot. You want to look between his toes. That's a place where you get a lot of athlete's foot. Nothing there. Brisk refill here. You want to check for edema. You can press. You want to start most distally because that's where you're going to notice the edema first. So press firmly, ideally with your thumb for about 3 seconds. Release and take the time to check to see if there's any indentation that's left from that impression. If there was edema here, then you start moving up the leg to see at what level the edema goes. Okay, but you start here first, and then you move up if there's edema lower, and you would want to check both legs. If you were worried about the possibility of a DVT, you might want to check for calf tenderness or do a Homan sign, which would be to flex up the foot, and he would experience pain in the back of the calf. Okay. The last thing you can do for testing the for a DVT would be to measure the calf circumference. So you want to pick a landmark. Tibial tuberosity works fine. And then measure about, pick a 10 centimeters too, so let's say 15 centimeters below that, and then check what the circumference of the leg is there, which is 35, and then measure with the same landmark going down the same distance, and measure the other leg and seeing if we have the same circumference. Okay. So you want to palpate your arteries. Now, when you auscultated your temporal and your carotid, if you felt them at that time, then you wouldn't have to repeat that. But if you wanted to save all the arteries and feel them at the same time, you can do that now. So feeling the temporal artery here, the carotids, I want to definitely feel just one at a time. It's dangerous to feel them both at the same time. As I feel the arteries, I'm noticing the amplitude of the pulse. I'm comparing one side to the other. Let me have your other hand. So right when we did the pulse and timed the pulse, I had already compared the radial arteries at that time, so I don't need to repeat that now. If you wanted to just do the pulse and do the comparison of the arteries at this time, that would be okay, but you had already completed that before. Brachial, you're going to feel in the antecubital space, and then you can feel them separately, but if you want to get the best comparison, then you can feel both of those at the same time. The other arteries we did as part of the abdominal exam, and those would be the femoral. So the popliteal or the popliteal is the artery going down in the, behind the knee. For this, you have to do one leg at a time. You can't do them both. You reach behind and just press in. You kind of have to lift up on the patient. You often have to move your fingers around a little bit to try and get that pulse. It's one of the hardest ones to get. If you didn't feel this pulse, but they had good, strong pedal pulses, then, oh, there's a good one there. Then you know that they had a strong popliteal. So don't be too worried if this one is hard to palpate. Lastly, then you want to do your pedal pulses. So your dorsalis pedis, you can have the patient lift up their big toe, and you're going to be palpating just lateral to that, so you can relax. And right around in here, if you don't feel it, you can move up or down a little. Don't press too hard, or sometimes you can occlude it. And then you can compare. You want to, whenever you're doing pulses, you want to compare right and left immediately or at the same time. Okay. And the posterior tibial is medial, and you want to feel behind the medial malleolus on both sides. And again, you can do those together if you want. So for the Allen's test, you want to, this is a way to test the patency of the ulnar artery. And so what you want to do is press firmly over the radial and the ulnar arteries. Ask the patient to make a tight fist, and then open their hand. And then you release the ulnar artery, and you see that the pink color returns to the hand quickly. And when that happens, then you can feel comfortable doing arterial blood gases out of the radial artery because they've got collateral circulation to the hand. And then the last thing you would do would be answer the questions that are on the bottom of the checklist.